Welcome, Jaclyn. I'm really excited to have you on the podcast today to talk about all things lichen sclerosus. Thank you so much for joining me.
Thank you so much for having me. I've very much been looking forward to having this conversation with you.
Yeah, I don't remember how I found out about you, but it's fairly recent. And somebody had highlighted the work that you were doing. I think it was actually at the UBC Sexual Health Networking Day. That's where it was. Yes. Yeah. I first of all, I really loved the name of what you were, your handle, I guess. And then I took a peek at what you're doing, and I just think it's fantastic. So really looking forward to this conversation. Thank you for saying yes. I always like to have my guest kind of introduce themselves in a sense of tell us a little bit of your story and what brought you to creating the Lost Labia Chronicles and focusing a lot of what you do in lichen sclerosus.
Yeah, for sure. So my journey kind of started in my early 20s, where I started to notice that sex was uncomfortable. Uncomfortable is the term I would use. At that point, it wasn't painful, but over the years, that discomfort kind of grew and evolved into what I would now say is painful. And not only that, I started to experience tearing with insertion. So if like a penis or even a tampon was tried to be inserted, I would get a tear at the kind of fourchette perineum area of the vulva, which I always thought, this seems a little strange. You know, when I chat with my girlfriends about our sex lives, no one seems to talk about the pain and the tearing and the bleeding and all of these complications. But I just kind of kept it to myself, and I would frequently go to STI clinics because the way that I received sex education, which was quite minimal, I associated anything going on in the kind of vulvovaginal region was either yeast or an STI. I didn't have that typical yeast discharge, and so I assumed STI. So I would go to these STI clinics, say, it hurts, it burns, it stings, I can't have sex. They would run all the tests and be like, everything is negative. And I'd be like, it has to be wrong. Like, this has to be wrong. And so then I started seeing gynecologists and family doctors, and they would all say, no, that's normal. This happens to everyone. I was like, really? Everybody tears open with sex? And they'd say, yeah, that's normal. You just are probably a really stressed, high stress person, probably really type A, and maybe you should try and find people who have smaller penises. Was pretty much the advice I got for 10 years. This kept up, and the intensity of the pain, as I was mentioning, just kind of kept progressing and progressing. And I was in grad school at the time, so I didn't have a family doctor proper. And I was kind of going to the university clinic, which basically had a rotation of different doctors. So it was always a new doctor looking at me. And by the way, I'm actually looking at me. Most of them didn't even look at my vulva and would just say, like, yeah, that's normal, you're just stressed. And so I moved to Toronto, Canada, and I found, this women's health, sexual health center. They seem to really have a different focus on genitopelvic issues. And so I thought, oh, I think I need to go here. I think they might actually know what's kind of going on with me. And so I went. It was a walk-in at this point, and I was there, the first person there with my coffee before they even opened, so eager to get in. And the doctor saw me, gave me a quick exam, she did, in fairness, look at the vulva, and said, yeah, you look fine. I can't do anything for you. So sorry you came here for nothing, but there's nothing I can do for you. And so I went to leave, I got the handle and went to go leave at the office, and she goes, oh, you could have multiple sclerosis though. And that really struck me because my mother actually had multiple sclerosis. And so I was like, oh no, this is way bigger than I thought. And she's like, yeah, but in any case, I can't help you with that. And that was it. And so at that point I thought, well, I kind of went at the highest level, what I thought was the highest level, and they had nothing for me. So I kind of gave up, and I left thinking, I'm not going to talk to doctors about my sexual pain anymore. I'm just not, because clearly this is in my head. Clearly I'm imagining this. There's nothing wrong with me. Like, how many doctors are going to tell me that I'm just too stressed? So I gave up. A couple weeks later, I went to my family doctor, and I was there for like low back pain or something, and I made a really offhand comment about my vulva, and she said, wait a minute, can we talk about that for a second? Tell me more about your vulva. And so I said, well, it hurts when I have sex. It burns. My vulva burns all the time. Peeing stings. I feel like I have paper cuts all over my vulva. Like there's 100 little paper cuts, and peeing feels like someone took rubbing alcohol and just poured it on me. I said tearing used to happen with insertion, but now I could go up a flight of stairs and I'll tear. My vulva will just tear. I barely move and it tears. I used to make a joke like, what caused that tear? I don't know. It was windy. Like it just tore so easily. And she said, would you mind if I gave you an exam? I'd like to look at your vulva. And I was like, well, I'm already here, so let's just do it. And then, so I went into the other room, got undressed from the waist down, got in the stirrups. She knocks on the door. She didn't even take 3 seconds before looking at my vulva, and she said, Jaclyn, you have something called lichen sclerosus. Of course, I was like, I'm sorry, what? Like, what is this? I've never heard of this. And then she proceeded to do a more thorough exam, explaining to me that basically my clitoral hood had completely scarred over the clitoral glands, that I had lost all of my inner labia, which kind of connects to what I ended up calling my whole knowledge hub later. So that inner labia was completely lost, and the color was so white. Everything was white, the texture was off. And so she's explaining all of this to me, and then we go back into her office and she goes, yeah, so it's autoimmune, there could be a hereditary component, it causes sexual dysfunction, and it can lead to vulvar cancer. Here's a prescription for topical, clobetasol, and out I went. And so I have to say, receiving that diagnosis really did put me in an incredibly dark place, and I fought very hard to get out of that dark place. And once I did, I started to really delve into the lichen sclerosus research. My background is in philosophy of neuroscience. I did my PhD looking at the different methods and protocols used in cognitive neuroscience to help us determine whether the conclusions drawn from these papers are reliable, robust, and trustworthy. So I started to just kind of apply those principles, sifting through the medical articles on vulvar lichen sclerosus. And then from there, I just kind of started to get really interested in lichen sclerosus as a whole, and I created my blog. Well, it started as a blog, and I called it the Lost Labia Chronicles because I had lost my labia to lichen sclerosus, and that was kind of my way of taking back that power. It was a really empowering thing for me to call it the Lost Labia Chronicles. It didn't really stay a blog for long. It kind of morphed into this knowledge sharing hub for evidence-based information and support. And so now I share a lot of content through YouTube videos, ebooks, webinars, blogs, you name it. And, I really focus on sharing a diversity of different content types so that it's accessible for many learning styles. So I basically went from philosophy of neuroscience to patient advocate and talking about my vulva on the internet, and here we are.
That is quite the story, and you had that moment of kind of giving up in a sense, like I'm not doing this anymore, and then just by complete fluke there was this other physician who happened to say something, but still that moment, even though she very quickly recognized it, she did want to pursue, she still sort of like, oh yeah, here you go, left you, and you were still left with what the hell do I do now, what is this, and
Precisely.
Starting your own. So good and not so good.
That's it.
Yeah.
I mean, we can always improve on things. Yeah. And, it's a little challenging, right? Because then I got a referral to a gynecologist. That wait time was 9 months. So 9 months is a long time not to know how to use your medication, not to know questions about treatment, not to know questions about overall care, adjunctive therapies, lifestyle questions. You're kind of just left to your own devices. So that's a long time for people to wait.
Yeah, and I'm in Canada as well, and that's it's an unfortunate part of our, I call it the sick care system. It's challenging. It's very challenging. So the resources you've created are incredible and are so helpful for people who are navigating, maybe not even having the diagnosis yet, but navigating the symptoms, the signs, everything we're going to talk about, and also I'm sure as you found, it's hard to find reputable sources of information. The internet can be a very scary, confusing place, conflicting information, and your background kind of served you well in that way to really help you navigate and find the right information.
Yeah, 100%.
So what is lichen sclerosus? You mentioned the word autoimmune. You talked about vulvar cancer. So what is it? What are the signs and symptoms of it?
Yeah, so lichen sclerosus is a chronic inflammatory skin condition. It primarily affects the genitals, so the vulva, the perianal skin. It can affect the penis as well. And it can, in some cases, affect the extragenital skin. So some people will also have it show up on their arms, chest, abdomen, their thighs. But it does have this preference for the genital area. So at its core, it's a skin condition. Kind of interestingly sits at this intersection of dermatology and gynecology. So dermatology because it's a skin condition, but because of where it's typically located, a lot of us go to the gynecologist because we think vulvovaginal gynecologist. So it kind of sits at that intersection. There have been a lot of recent developments in genomics research lately, and that's where the autoimmune component comes in. They've started to really isolate all of the cells and molecules and the whole autoimmune process that occurs in the skin that leads to high levels of inflammation, which then causes the signs and symptoms. And so the way that I explain the difference between signs and symptoms is signs are things that we can see. So if we're looking at the vulva, you're talking about color changes, texture changes, changes to the physical appearance of the vulva, and then symptoms are things that we feel in our body. So I feel itch, but you can't see itch on my body. You may be able to infer it if I've been scratching, and you can kind of see those scratch marks, so you can infer from the scratch marks that maybe I'm an itchy person or I'm experiencing itch, but you can't typically see itch. And so in terms of signs, what you're kind of looking for are texture changes. So for some people, that can be really thick skin, like thick plaques of skin. So if you look at the surrounding skin, it looks kind of smooth, and then there's this plaque of really thick raised skin. In some people, it's kind of the opposite. It appears a little bit more thinned out. They kind of describe it as looking like wax paper. They used to say cigarette paper, but then they're like, no one knows what that is anymore. So they kind of switched over to like, let's say like wax parchment paper, right? It's thin, it's glossy, you know, it's wrinkly. So texture changes. In terms of color, there can be a loss of pigmentation. So we all have different colored vulvas naturally, but whatever your baseline color is, you can start to experience a loss of pigmentation. So that pigment starts to fade and the color looks lighter and lighter and lighter. That's also going to present differently on people of different skin types. But overall, it's this loss of pigmentation that you're kind of looking for. Sometimes there can be some redness. There can also be bruising. Again, the color of the bruises are going to depend on the color of your skin. It can be anywhere from like a bluish color, red, brown, etc. You can have blood blisters. Those are, you know, a couple of other things that can happen. And then you can also get things that, you know, we kind of call in the LS community architectural changes. And these are things like fusing or scarring. So I have this little vulva puppet for anyone that's tuning in on YouTube. And basically, I've got this dark navy hood here and this little pink ball. So the pink ball would be the glans clitoris, and this navy hood here would be the clitoral hood. So all of our clitorises look different, right? And you know, some people, the glans is kind of a little bit more exposed at rest. Some people, it hangs a little bit more over. But typically, if we try to retract the hood, which is to pull it upwards and back, we can kind of expose and see that glans. What happens with lichen sclerosus, because our skin is really prone to fusing and scarring, this hood can actually fuse, so stick to and scar over that glans, such that if you try to retract and pull it back, nothing happens. Not only can you not visualize the glans, but it barely moves. Some people do have partial fusing, so maybe you can see a little bit of the glans from one side, like the right side, but not the left side. Another area that can be impacted is the inner lip, so the labia minora. And that's what I was saying, the Lost Labia Chronicles, right? I lost these inner lips. What happened to me was not only did they start to stick to and fuse to the outer lips, but they actually absorbed. So the labia minora basically got resorbed by the labia minora. So you can kind of no longer see, you could see maybe a color change as to where they used to be, but they've kind of just absorbed into the surrounding tissue. There can also be scarring at the opening of the vagina, and so that can happen if there's a lot of tearing. So each time you tear, scar tissue develops, and that process, if you keep tearing, more scar tissue, and that can kind of build and narrow the vaginal opening. So there's a lot of different anatomical changes, scarring, fusing that can happen to the vulva. That's what we're looking for in terms of signs. In terms of symptoms, itch. And itch can present very differently for different people. So it can be very mild, sporadic, and random to constant, chronic, debilitating. I know people that wake up with blood under their fingernails because they've been scratching all night because the itch is so intense. Pain, and then pain presents, it's kind of this umbrella. Some people will say soreness, aching, a fullness, a tightness, a pulling. It's usually related to fusing. Some people have chronic burning. Some people have pain with insertion. Some people have tearing with insertion. And so those are some of like the main signs and symptoms that can present with lichen sclerosus. You definitely don't need to have all the signs, all the symptoms to have it. It's really quite varied in the community in terms of how it presents. There are also asymptomatic people who are quite surprised when they go for their yearly checkup and the doctor says, you have lichen sclerosus, and they're like, what do you mean? Because they don't have any itch, they don't have any pain, they don't have any sexual health issues. So they're completely taken off guard, but they do have the signs. So when they're, getting their gynecology check, there's probably some fusing, some loss of pigmentation, some color changes, and they're just like, what? Like, that's okay, I guess. So yeah, that's pretty much lichen sclerosus in a nutshell.
As you're describing that, and thank you so much for the demo. I'm also a fellow vulva
Yes.
puppet. I love great teaching tools. As you were demonstrating the changes, my first thought initially as you were talking about how the hood can fuse, I'm thinking from a pleasure perspective, that is a one key main source of pleasure for women. How does lichen sclerosus, will it impact or influence pleasure for everyone? Can it depend on the degree of anatomical change? Does it happen, does it not influence? I can't imagine that it wouldn't, but.
It definitely can influence, but not for everyone. What's interesting is that the degree of fusing doesn't necessarily dictate how you will feel sensation. So some people have full phimosis. Clitoral phimosis is the medical term. So it's completely scarred over, but they actually still have sensation. So if they are, stimulating that area with a finger, they can still feel it, and they can certainly feel a vibrator. Some people will experience a loss of sensation, so they say it feels dulled, right? I feel it. I feel a finger, but it feels almost, as if I'm touching my mug with a pair of ski gloves or really thick pair of gloves. I know it's in my hand, but I don't feel it nearly as distinctly or sharply as when I'm holding it with my bare hand. And some people have mild fusing, or you can pull it back a bit. It's not fully fused, but they'll experience a significant loss of sensation. So everyone is kind of different, but there's definitely a pleasure aspect to the clitoral phimosis piece, and a lot of people will talk about dulled orgasms, delayed orgasms, orgasm issues, and just sensation issues in general.
The other piece, as you were talking, was you were talking about insertion, which lots of things can be inserted, and I'm also thinking about things coming out like babies. So from a vaginal childbirth perspective, is there evidence for greater tearing if somebody has lichen sclerosus? Is there an indication that I don't know of any contraindications that you couldn't give birth vaginally, but somebody maybe might choose not to, perhaps?
Yes, and that's often what you see. So actually there was a recent paper published in, I believe, 2023 that kind of did a big update on pregnancy, because pregnancy and vulvar lichen sclerosus research has pretty much been limited to kind of case studies or very small patient populations. You're looking at 10 people per study, and so this one looked at, I think, about 200 people with vulvar lichen sclerosus who gave birth. And there's quite a lot of spontaneous vaginal births. Those that did a C-section, most of them chose to just because they were worried about the tearing, but there's no indication of you need to do a cesarean. Most people that I know with vulvar lichen sclerosus end up doing a vaginal birth, and the tearing is something similar to regular rates and degrees of tearing, although there are certainly people that will tear more severely with lichen sclerosus. And that also depends on, are they treating during their pregnancy? Are they not treating during their pregnancy? Are they working with a pelvic floor PT to do, you know, kind of perineum massage and prep for the birth itself? There's a lot of pieces that I think kind of play into how delivery happens, but certainly a lot of people give vaginal births, and most healthcare providers will say, really, I mean, it's up to the patient to choose their mode of delivery.
With regards to diagnosis, you talked about the incredibly long journey with misdiagnosis, or nobody really even, the fact that nobody gave you an internal or even like an external, it boggles my mind.
Yeah.
So anyway, you finally had one doctor who looked, and you, as you say, very quickly she knew. Mm-hmm. What do we need to have in terms of an evaluation to receive the diagnosis of vulvar lichen sclerosus?
So at bare minimum, you need a clinical examination. So technically speaking, the gold standard for diagnosis is a punch biopsy, but you can also be diagnosed via a clinical examination. So clinical examination is essentially listening to the patient's history, listening to the symptoms, and then taking the time to examine the vulvar tissues, looking for those signs of active lichen sclerosus. So looking at the texture, looking for architectural changes, for fusing, for pigmentation changes, for stuff like that. Sometimes that's sufficient. If the doctor is well versed and very knowledgeable and comfortable in their diagnosis, then that sometimes is all it takes, and people will just make that diagnosis clinically. So in my case, you know, the whole vulva was white. I was completely scarred over. Like, they were like, there's no doubt in their minds. And actually, you know, because you could probably talk 1 hour just about my whole diagnosis story, but I went to 7 different doctors after begging for a biopsy. They all declined, saying that my case was textbook lichen sclerosus. There was no need to traumatize the vulvar tissue, that this was such a clear and obvious case that there was no need to do the biopsy. And eventually I was just like, okay, all right, I'll drop the biopsy. So at bare minimum, though, you do need to look at and examine the skin. This is really important. We saw a lot of issues during COVID with telehealth and people being diagnosed with vulvovaginal conditions over the phone. The problem is that almost every vulvovaginal condition itches and hurts to some capacity. When it comes to lichen sclerosus, you have to see the skin at a bare minimum. And then if you're not confident in your diagnosis, you think there's a couple differentials, you suspect vulvar cancer, anything like that might merit a biopsy. They do biopsies a lot more in the United States also for insurance purposes, because in the United States, there's certain states where if you do not have biopsy proof that you have lichen sclerosus, they will not cover your medication. So there's always complicating factors when we think about these, but those are the 2 main ways that it's diagnosed.
When you were seeing 7 different doctors for the biopsy, was that something that you wanted confirmation for? That was sort of your pursuit to say, is it really? Is it really?
Yeah, basically, yeah. And, you know, the few articles that I did read in the beginning were like, biopsy is gold standard. And I was like, okay, so I need the biopsy. And they were like, no, you don't. Like, if we really weren't sure, because there's also like this umbrella of lichenoid conditions. So there's like lichen planus, lichen sclerosus, lichen simplex chronicus. Even if there was some uncertainty as to could this be lichen planus versus lichen sclerosus, maybe a biopsy could have been done. But everybody was like, this is just so clearly lichen sclerosus that there's truly no need for a biopsy. And then I just finally, I was like, all right.
Okay.
And
lichen planus, what's the differentiating factor between those 2 conditions? And the other one I haven't heard of before that you named, the third one.
Yeah, lichen simplex chronicus. So lichen simplex chronicus is basically an itch scratch cycle. So anything can trigger this, say a yeast infection. So you get a yeast infection and you're itchy. If you're one of those people that just can't help but scratch, You start scratching, that releases mast cells and histamines, which makes you itch more, which makes you scratch more. And then you get stuck in this itch-scratch cycle. As you're scratching, you can also damage the skin, you can thicken the skin and, you know, create kind of open sores. And so that is a little bit different insofar as it's not considered a chronic condition. It's considered more, you know, short term. And they're looking more at ways to break that itch-scratch cycle. And then once that's kind of broken, you just kind of go back. Lichen planus is very similar to lichen sclerosus, and sometimes that is when a biopsy can be helpful in order to discern the two, because there's so much overlap. It can also cause scarring to the vulva, it can cause pain with sex, it can itch, it can look similar to, especially to somebody who's not super trained in differentiating different vulvar dermatoses. One difference is that lichen planus, erosive lichen planus, it can go into the vagina as well. So lichen sclerosus, the main consensus is that it affects the vulva, the outside genitals. Now it can affect the opening of the vagina, so around there, kind of at the opening, but it doesn't really go deep into the vagina, whereas you can find lichen planus deep in the vagina. So typically treatment is going to differ as well, because you're going to be treating the vulva and the vagina, so you're going to have some extra prescriptions and some extra things that you're going to need to do. But those are kind of, you know, the main differences. We used to say that like lichen sclerosus looks more white, lichen planus erosive looks more red, but even that is not always clear cut. There can be both, so what do you do with that? They look very similar, so sometimes a biopsy will be done. Sometimes oral lichen planus, so if somebody has oral lichen planus, then they might kind of make that connection of, okay, if they have oral lichen planus and they're complaining about symptoms in the vagina and I'm seeing redness in the vagina and all of this, they might, again, make a more clinical diagnosis, but sometimes a biopsy will just help kind of rule one out and make it clear. And you can have both is the other thing.
Yeah, I was just going to ask,
yeah.
Can you, okay, you can.
Yeah,
okay.
You can definitely have both.
Okay, interesting. So, all right, we've talked signs and symptoms, diagnosis, and now treatment. We've talked a little bit about the treatment piece. So the one kind of common treatment I've heard is steroid, and it's pretty much you have to use steroids as a help to mitigate the risk from vulvar cancer. So I want clarification on that. And then the other one that I've recently been reading a little bit more literature on is PRP, which I think is super cool in many ways. But can you start with kind of the standard treatments now, and then we'll kind of go into the cooler ones.
Yeah, absolutely. So you're correct. The gold standard treatment is topical applied to the skin. Either ultra potent or potent corticosteroids. They are typically, or it's recommended that you get it in ointment form and not cream. The cream bases have alcohol, which if you have open sores, cuts, tears, it's just going to burn. So if you're listening and you have lichen sclerosus and your provider gives you the cream, just ask them to swap for the ointment. It's prescribed where you treat more aggressively in terms of your dosing initially, and then you taper that dosing down to something called a maintenance protocol, and that is right now for life. So maintenance protocol is anywhere from 1 to 3 times a week. I do mine 2 times a week, and I have done that since I've been diagnosed, basically. So that is the main treatment. That's definitely the treatment that has the most evidence-based behind it in terms of supporting its ability to calm symptoms, get patients into remission, slow the progression of the disease, and reduce the risk of vulvar cancer. To date, that treatment is the only one that suggests the decrease in developing vulvar cancer. No other treatment has been, well, we don't know, right? No other treatments have been kind of put to that test in terms of, does it also reduce the risk of cancer? So right now, that's the only one that we can kind of with confidence say decreases that risk. And again, there's so much research, so many randomized controlled trials kind of supporting the safety and efficacy of topical corticosteroids. They're the ones that are going to reduce inflammation the most. So in order to be a treatment, you want it to address symptoms and signs. You need that inflammation to go down. So if you have high levels of inflammation, they need to see on a pre and post biopsy a serious decrease in the levels of inflammation. They need to see that go down. And steroids right now are unmatched in their abilities to do that. There are randomized control trials against PRP, laser, all these other modalities, energy-based, regenerative medicine, and nothing else shows that statistically significant drop in inflammation other than topical corticosteroids or the second-line treatment, which is topical calcineurin inhibitors. So that's also a cream applied to the skin. It's an immunomodulator, also working to reduce that overactive immune response and subsequently reduce that inflammation. In a randomized control trial between steroids and calcineurin inhibitors, they performed quite similar. The steroids still did better at reducing inflammation, but the calcineurin inhibitors dropped it down quite significantly, enough to report a statistically significant drop. So those are kind of the two main treatments. Then you move into energy-based, that's laser, regenerative.
Before we move there, sorry, I just want to interrupt before I forget this thought. Two questions. One was, you said potent and ultra potent. Is that what the words that you used? What's the like? I can infer like there's more. It's a higher dose, but is that as simple as that? And how do they determine somebody that needs potent versus ultra potent?
Right. So there's actually like a ladder of steroids, like a ladder that you climb, right? So ultra potent's at the top, and then you kind of have weak at the bottom. That would be your standard kind of hydrocortisone that you could walk into any pharmacy and basically just grab off the counter. And then in the middle, you have all these different mid-potency steroids. So no matter what, the truth is treatments are never one size fits all. It's never clear cut. The gold standard is clobetasol, which is ultra potent. But truthfully, sometimes it takes some trial and error to see what potency works for the patient. I think, and this is just my opinion, that in an ideal world, providers would work very closely with patients in the beginning to see how is the skin responding to the medication and adjusting accordingly. Because for some people, ultra potent is just too strong, and all you need to do is drop them down to a mid-potency, something like triamcinolone, and all of a sudden they start responding, the side effects they were experiencing go away, and they start doing really well. So it really, dosing and strength is something that I think needs to be tailored to the individual based on their symptoms, their signs, how they respond, and any side effects that they may be reporting. Of course, it's never as simple as that. We work in medical systems that are complex and complicated, and I waited 3 years to get into a vulvar specialist, so you would believe that that's not the kind of care that I received, but I do think that's ideally how it should be done. And I think that if people are experiencing side effects from ultra potent, to maybe come in and talk to their doctor about, what if we drop it down? What if we do a mid-potency steroid? Could we try that? This seems to be too strong for my skin. It seems to be making me really raw and irritated and in pain. Could we maybe drop it down? Could be one way to approach that.
And when I think of, any time that I think I've had like a hydrocortisone prescribed a couple times in my life, and it's always been used sparingly, don't use too often, it can thin the skin.
Yes.
So if I'm thinking about tissue that's already thin and, susceptible to tearing, is that not exacerbating it to some degree?
That's a great question, and that's a very logical question to ask. It makes perfect sense. And in fact, my doctor, when she prescribed clobetasol, told me, use it, but use it very sparingly. It can thin the skin. And a lot of pharmacists tell their patients this too when they go to pick up the medicine. Oh, be careful. Some even say don't use it past 2 weeks. It's dangerous for the genitals, even though there's rigorous pharmacokinetic research on this showing that that's not true. But nonetheless, that's the information that we get. So when it comes to lichen sclerosus is a skin deep condition. What that means is that it affects all 3 layers of skin. So you have the epidermis at the top, the dermis in the middle, the subcutaneous or hypodermis, that's like that basement layer. So lichen sclerosus affects every single layer of skin. And lichenification actually means thick, and sclerosis is hard, rigid, stiff. At its core, what lichen sclerosus does is it actually thickens the skin. So if you look at a sample, a biopsy sample, and you look at the kind of histopathology report, it's characterized by serious thickening. And in fact, lichen sclerosus skin, that top layer, that epidermis layer, has a bunch of little layers inside. One of them is called the stratum corneum, and that stratum corneum is several times thicker than non-lichen sclerosus skin. So everything below it, even though what we see, that top most superficial layer of the epidermis, that can appear thin to us, but all those layers immediately below are characterized by very hard, very stiff, very rigid skin. In fact, that's why we tear, because our vulvas lack the elasticity, that mobility to move and to accommodate. So if I'm trying to insert something into the vagina, instead of that opening just moving to accommodate, it doesn't know what to do. It's hard, it's thick, it's stiff, so it cracks open. And that's why we get those fissures, those cuts, those tears. And so part of it is understanding that even though what we're seeing on top is thin, the layers below are thick, and those are the layers that we're trying to attack. We need that medication to go all the way down to the bottom. And to address that, first of all, there's no studies that have actually demonstrated skin thinning.
Yeah.
It's the hardest thing to say. Skin thinning from topical corticosteroids used in people with lichen sclerosus. You do see this in other skin conditions like eczema. So a lot of people infer if this happens from eczema skin, it'll happen to vulvar lichen sclerosus skin, even though again our stratum corneum is 7 times thicker than in eczema patients. But the key here is to apply your steroid optimally. So what we don't want is what I was doing at first. I would squeeze some steroid out of my hand and I would plop it on the vulva like that and leave a thick layer on that top layer of skin. So what you're supposed to do, or the kind of recommendation, is to soak for 15 minutes prior to application to soften those thick, hard layers a bit, to open those pores, to make it such that that medication has an easier time getting through the epidermis to the dermis all the way down to that basement layer of skin. And the recommendation is also to make sure that you're adequately rubbing that medication in, so you're not leaving it on the surface where you may have thin skin. You're kind of moving it past and getting it down into those deeper layers where we need it to go, instead of just leaving it on potentially thin skin. So a lot of those concerns can be mitigated by education about proper application and about what's going on at each layer of our skin.
So interesting. One more question before we come back to the other cool
Yeah.
therapies. But what is it that increases the risk of vulvar cancer with lichen sclerosus? And is it also is the same risk there with lichen planus and lichen, the other one you
Lichen
said?
simplex chronicus.
Simplex,
yeah.
yes. Thank you.
Yeah, as far as I know, there's no cancer risk with lichen simplex chronicus. I'm not as certain with lichen planus. That may still be there. I know for sure with vulvar cancer, the risk is 2 to 6%. You'll see those statistics slightly range depending on the studies, but most systematic reviews are going to quote you a 2 to 6%. So what happens in the initial stages of lichen sclerosus is you have this overactive immune response in the deep layer of our skin. In that basement layer, there's basically something that triggers it. We're still not sure what that something is. Researchers speculate it could be certain medications, it could be trauma to the genital pelvic area, it could be certain infections that kind of trigger that autoimmune reaction, where basically our bodies say, holy crap, that's not me, and start attacking. That attack basically creates this highly inflammatory response. So you've got high levels of inflammation and cellular disorganization. As that progresses, that starts changing all the layers of skin. And because lichen sclerosus is progressive, if it's not treated, that inflammation rises, that cellular disorganization occurs, and then oxidative stress starts to happen, and then there's the downregulation of tumor suppressing genes which can occur. So basically downregulation meaning that there's less tumor suppressing genes than there should be, and the ones that are there are not doing their job optimally. They're kind of slacking a bit, right? And so all of those factors combined is what can in some cases lead to vulvar cancer. And that's why a lot of the lichen sclerosus specialists are very adamant about treating with topical corticosteroids to reduce that risk and keep folks healthy.
Yeah, very cool. Okay, so now moving on to the other kind of adjunct, maybe they're not even considered adjunct therapies, I don't know, but the PRP, so the O shot, that is something that in the line of work that I do, many people ask me about that. The O shot is PRP, platelet-rich plasma, and it's offered as more kind of sexual enhancement. Right. Off-label, it's recommended as potentially not a cure, but a treatment for the management of lichen sclerosus. So that's one. I'd love to get your thoughts on that, and any others that you know of that can be helpful.
Yeah, of course. So platelet-rich plasma is something that definitely piques a lot of interest. As you say, it seems more cool. I mean, it definitely sounds more interesting than a cream. For some people, it sounds pretty scary, because essentially what they're doing is a clinician's going to draw your blood, put that in a vial, plop it into this little centrifuge machine. It's going to spin that around, and as it's spinning your blood, it's increasing platelets, which contain growth factors, which can help in tissue repair and tissue healing if the tissue's been damaged, which clearly with lichen sclerosus, there's damage to the tissue. We want that tissue to heal. So now they have your blood with those increased platelets and growth factors. They're going to put that in a syringe, they're going to numb the vulva, and then they're injecting that all over the vulva. How many injections, where they do it exactly, that's going to basically vary per clinic and per practitioner, whoever's doing it. But that's the gist of what they're doing, which again can sound intimidating, because the O shot is typically, as you say, it's kind of marketed in this, let's enhance our sexual pleasure. But if you've got someone who has lesions all over their vulva and is in excruciating pain, the thought of getting injected with a needle over and over again is not the most enticing thing. But nonetheless, there is a lot of interest in it. Unfortunately, the studies do not support it as a treatment. There's just not any safety or efficacy data supporting the use of platelet-rich plasma in the context of a treatment. So what you do see in these studies is that patients do report feeling better and looking better. And I say that, and I really want to emphasize that, because that matters too. Your symptoms matter, your quality of life matters. Again, in terms of treatment, when it's put in a randomized control trial against the gold standard, which is the topical corticosteroids, the steroids bring that inflammation down significantly. PRP doesn't reduce the inflammation. So you may feel better, you may look better, but you've still got significant amounts of inflammation that we do want to reduce that vulvar cancer risk, to reduce, more anatomical changes to the vulva. So in some instances, it could potentially be an adjunctive therapy for some people, used in conjunction with a steroid if the steroid's not getting them where they want to be and they want to try platelet-rich plasma. It's more about understanding that it's not approved as a treatment per se. There's not enough safety and efficacy data to support it at this juncture. That could change. There's stem cell, similar results. There's a randomized control study right now being conducted in the UK looking at fat grafting. That one's really interesting. So basically fat has stem cells and adipose-rich cells, and you're going to take some of that fat from one area of the body and basically put that into the vulva. They're looking to see if that helps with symptoms and with sexual health symptoms in particular, as well as improving the overall look of the vulva. But that's currently in trial, so we're not going to really know too much about that. There's also energy-based modalities, which is laser, ablative, and non-ablative. Ablative is the most popular one. Most people probably know it as Mona Lisa. CO2 fractional laser. Again, some people say they look and feel better, but when it's put to a randomized control trial, we don't see that reduction of inflammation. So again, it's considered more of an adjunctive, if anything. And these can cost a lot of money, so it's just important that folks know that it's not affecting the levels of inflammation that we want to see addressed.
Mm-hmm. Mm-hmm. Is it possible you've mentioned the word remission, so is it possible to achieve remission? What does it mean if somebody was considered to be in remission, if that's possible?
Yeah, so it definitely is possible. It's a little bit complicated because when you talk about remission, most doctors are talking about clinical remission. And clinical remission means there's no signs of active lichen sclerosus. So signs, which means you can still technically have symptoms in remission. In remission, you're less likely to have itch as a symptom, but you may still have sexual health symptoms or pain symptoms. And usually what's happening there is it's relating again to the fusing and scarring that's already occurred. So steroids are great at reducing inflammation. One thing they're not good at, or they can't really do, is reverse scarring that's already occurred. So let's pretend that this is the vaginal opening and we have this shelf of scar tissue here that's built up over time. Now that scar tissue is already there, but I don't have any new scar tissue. The texture overall looks good. The color's returned, everything, they're like, great, it's in remission. But because that scar tissue is there, and again, scar tissue is very tough, it's thick, it's rigid, I keep tearing every time something is inserted. And so I get another tear, which is painful. It's causing sexual health issues. It's causing pain. And so that you can still have sexual health or pain-related symptoms in remission. But getting into clinical remission is definitely possible. I have been in clinical remission for 4.5 years, and I've also been symptom-free for that 4.5 years. So no sexual health symptoms. And for me, it was very much like sexual health symptoms were the big symptoms I was suffering from. So I don't have any of that. No itch, no pain, no burning, no complications. I don't really think about LS anymore.
Amazing.
Other than the work that I do, but it doesn't take up any real estate in my head the way that it used to in a negative way. So it's absolutely possible to get in remission, but it takes time. And it does take patience and some trial and error. Again, like steroids, it's not a one-size-fits-all, and some people do need to combine, and some people do achieve remission, and that missing piece was they did a couple laser sessions, and now everything looks great. So it's never as clear-cut as this is the only way to do it. I think there's a lot of things that we can add into our overall care and how we manage and treat to get to that point. But it takes creativity on the provider side too.
Mm-hmm. Yeah, and from an autoimmune perspective, so autoimmune is I hadn't really thought of or really understood the word until I had an autoimmune thyroid condition, which is very common for women, and which is Hashimoto's, and thinking about how we go sort of from a treatment or managing autoimmune conditions, there's diet and lifestyle and red light therapy and LDN, low dose naltrexone as a medication.
Yeah.
So are all those things, like, have you used any of those, or was yours just the steroid cream?
Yeah, so for me, I would say a big part of the heavy lifting for me was steroids. That said, I tell everybody that I speak to with lichen sclerosus, you can throw all the steroids at your vulva, but if you are not paying attention to your stress levels, to your sleep, to all these other factors, it may not be enough. And so while I didn't make any changes to my diet, because I never really noticed any connection, like there didn't seem to be like, oh, every time I eat gluten, I itch or something like that. Like I didn't really seem to have this diet component, but I did spend a lot of time really focusing on stress reduction techniques, on nervous system regulation, on proper sleep. I think those were the big ones for me. And then also just overall care. So using an emollient, which is basically a moisturizer for the vulva to keep that protected, soothed, and those were the big things for me. Pelvic floor physical therapy was another, making sure that my pelvic floor was happy and healthy. So really, again, everyone's kind of overall package is going to look a little different. There are some people where there's such a clear and obvious connection to what they're eating. I know one person that if they eat a grain of corn, like a single grain, they will itch for like 3 days without fail. And all that person needed to do was just stop eating corn to get their symptoms out of control. Some people it's nightshades, some people it's this, but again, it's never one size fits all. But I do think it is about thinking a little bit more outside of just our main treatment. What else can I do to support overall health and well-being? If my mental health is struggling, reaching out to, a therapist or a counselor, someone to get that mental health support. I worked with a sex therapist for about 4 years. So, there's all these other things that I was definitely doing to support the different facets of my life.
One more question before we wrap up. I'm going a little over time. I apologize, and thank you for your information. The other place my mind goes is the population that I support mostly now is the perimenopause, menopause population that are now experiencing genitourinary syndrome of menopause, which is another signs and symptoms syndrome, and dryness, itchy, burny, like a lot of the symptoms that you've listed. Mm-hmm. Even to some degree, some of the signs, like not all of them, but there can be thinning and
I agree.
and right. So that can be confusing, and the gold standard here is vaginal estrogen. Is there any contraindication for vaginal estrogen with lichen sclerosus or is it something that could also be beneficial to people with lichen sclerosus?
So Doctors Goldstein and Kraft, they both are affiliated with the Center for Vulvovaginal Disorders in the United States. They actually prescribe a combination of testosterone and estrogen to most patients with lichen sclerosus, regardless of age. I'm 37, and I use topical estrogen as an adjunctive, because basically it can really do a lot of help with respect to supporting, like you said, genitourinary syndrome symptoms if they're present, but also in the context of lichen sclerosus, it can kind of plump up the skin. It can bring back elasticity and moisture to the skin. Steroids do have a slight drying effect, which is why we really want to keep it moisturized and stuff down there. So it's definitely not contraindicated, and in fact, a lot of people end up getting prescribed both. I think the big challenge is there's so much overlap, as you mentioned, between GSM and lichen sclerosus, and that causes a lot of confusion in terms of diagnosis, and a lot of people come in with symptoms, get told it's genitourinary syndrome of menopause, get a prescription for estrogen, which great, but they also have lichen sclerosus, and that wasn't diagnosed, and that's not going to be treated with estrogen. Estrogen is an adjunctive. When it comes to lichen sclerosus, it's not a treatment, nor is testosterone. So it's like, that's the tricky part. And again, that's why it's so critical to get in the office, in a specialist office that knows how to really look at the skin. Because if I call you up and tell you my symptoms, it could be yeast, it could be GSM, it could be BV, it could be so many things. Yeah. And there is so much overlap between LS and GSM. And even to an untrained eye, if the gynecologist is not super familiar, they may even miss that too. Yeah. So it's really, it's a big challenge for sure.
Yeah. You are a wealth of knowledge. Thank you so much for sharing everything with us, and thank you for the work that you're doing. Where can people find you to learn more and take advantage of all the resources that you share on your website?
Yeah, of course. So I'm most active on Instagram at the Lost Labia Chronicles. I'm also on Facebook and TikTok at the Lost Labia Chronicles for all of that. And then my website is lostlabia.com. Highly recommend that anyone interested downloads my free ebook. It's over 100 pages of evidence-based information, 40 plus peer-reviewed articles went into that, and I review it yearly for any new scientific updates. So that is constantly in the works, being kept fresh. So definitely folks can check that out and grab that on my website.
That's amazing. I'll share all the links in the show notes. But thank you so much. Amazing information. This will help so many people. I really appreciate it.
Thank you so much for having me. I really appreciate it.